Good evening. Thank you for having me to share with you about detecting and monitoring glaucoma with Swept-Source OCT Wide-field Imaging. The take-home message of this talk is that when we detect and monitor glaucoma, we actually need to go deeper and go wider. So what do I mean by go wider and go deeper? Now let's take a look back to the definition of glaucoma. When we had the 10th World Glaucoma Association consensus meeting in 2016, we had a panel of glaucoma specialists from around the world to talk about how to diagnose glaucoma. And here we have a definition which we define glaucoma as having a thin retinal nerve fiber layer and narrow neoretinal rim. Now, most of us here are very familiar with optic disc evaluation, measurement of the rim width. But why just measurement of the rim is not enough when we want to detect change in glaucoma? Why do we need wide field imaging? Here is an example which shows you the right and left optic disc of a patient. Here, when we look at the right eye, the vertical cup-to-disc ratio is enlarged and there's loss of the rim over the inferior port. And on the left-hand side, actually, we don't see any obvious neoretinal rim loss. The cup-to-disc ratio, in this case, about 0.6, 0.7. We can actually quantify the rim, get a more reliable measurements of the rim width using here the Swept-Source OCT. The minimum rim width measurement here is derived from the BMO to the nearest ILM. Here is what we called as the minimum rim width. And over the infratemporal side, you can see the measurement, the minimum rim width measurement is outside the normal range. But on the left-hand side, you don't see any measurements outside the normal limits. So we don't see any loss of the rim over the left eye. This is the circumpapillary retinal nerve fiber measurements obtained from the size series OCT. Many of us here are familiar with the clock hours and the quadrants annotations of the RNFL thickness. When we see red, it indicates the measurements are below the normal reference limits. Green is within normal limits. But I encourage you to look beyond the ring, to look beyond the circle measurements, because with in the old days, OCT is slow, and that's why we couldn't image an area of the retina. But here with the spectral domain OCT, we can measure retinal nerve fiber here in a map, in the 6x6mm map. We should actually go beyond the range because the map analysis provides much more information compared with the circle measurement. Here, for example, we are already able to appreciate a patch of loss of the retinal nerve fiber layer over the infratemporal side. The thickness map show you the loss of the thickness because you can see loss of the red indicates thick, blue indicates thin in the RNFL thickness map, and you can see the symmetry in the thickness map. The deviation map show you when the measurements are below here, the first percentile will show up as red. So by comparing the thickness map and deviation map, you can get a very good understanding about where the retinal nerve fiber defects are. For the left eye, you don't see any abnormalities in the RNFL deviation map, and the thickness map also appear to be quite normal. You can see the red pixel, the red annotation of retinal nerve fiber layer for both the superior temporal side and the infratemporal side. So you may argue that, well, we don't see rim loss, we don't see RNFL loss of the left eye. Does it mean that the left eye is normal? It's actually only when we study the macula, we are able to appreciate loss of the GCIPL, the ganglion cell in the plexiform layer over both the right and the left side. So it is important not only to look at the parapupillary region, we should go beyond the parapupillary region and to study the macula. We studied RNFL over the parapupillary region. We study the GCIPL over the macula because the macula has relatively thin retinal nerve fibrilla, but relatively thick GCIPL because the density of RNF of the retinal ganglion cell is highest over the macula. That's why we measure the GCIPL over the macula. We measure our NFL over the optic disc is because all the axonal fiber bundles coming from the RGC retinal ganglion cells from the retina, they all converge at the optic nerve head. So that's why we measure the axonal fiber bundles thickness over the palpopapillary region because it represents the collection of all axons coming from the retina. And in this case, we need to integrate both macula and the palpopapillary region in order to maximize the detection of change, the detection of glaucoma damage. The size instruments only provide you a scan of one region at a time. You need to separate scans for the macular and the palpopapillary region. But using the Swept-Source OCT from topcon, here is the triton OCT, we can actually image both area using the same scan. Here is the 12 by 9 millimeter scan generated from the triton OCT. The GCL++ indicates the combined RNFL and GCIPL thickness. GCL plus in the middle column show you the GCIPL thickness, and then the RNFL is the RNFL thickness in the bottom panel. The thickness map is on the right, it's on the left, and the deviation map or the probability is on the right. The right eye and the left eye, you can see the damage is obvious over the inferior side for the right eye, but it's actually not that obvious on the left. You can see no particular change of the RNFL in the probability map, and of the macula, you can appreciate perhaps there's some abnormality of the inferior macula, indicating here in both the GCL++ thickness map and the plus thickness map. But because the pixels doesn't really conform to any known trajectories of the axonal fiber bundle. So it's really hard to know whether these pixel changes are false positive detection or they are genuine loss of this GCL and RNFL layer. We developed technology, we call this ROTOR, some years ago. ROTOR stands for Retinal Nerve Fibrillary Optical Texture Analysis. What it does is that it integrates both the thickness measurements of the RNFL and the refractivity measurements of the RNFL. We integrate these two parameters together to generate a signature to represent the individual axonal fiber bundles. So with ROTOR, we can actually track the trajectories of these individual axonal fiber bundles. I apologize, I don't have time to explain how this ROTOR is derived, but those of you who are interested can follow the manuscript here. The appearance of the ROTOR map is like this. We are able to capture the trajectories and the optical texture of these individual axonal fiber bundles. We can appreciate the papillomacular bundle. We can appreciate the axonal fiber bundles over the temporal raphe. Here we see the superior and the inferior axonal fiber bundles almost merge at the temporal raphe. And then this is the superior arcuate bundle. You can see the arcuate shape of these axonal fiber bundles over the superior retina. And the inferior arcuate bundles, you can see the individual bundles. The nasal side or the radial nasal bundles are generally not well seen in the raphe photography or in conventional OCT analysis. But with ROTOR, we can capture these signals. We can capture the axonal fiber bundles. We can capture the striation of these axonal fiber bundles over even the nasal side. So it's a powerful technique to show where the nerve fiber layer abnormalities are. Here again, we look back the right eye, the thickness map or the probability map from the OCT analysis show us the damage occur mostly over the inferior side. But it's actually only when we look at ROTOR we can appreciate loss of the RNFL, loss of the axonal fiber bundles actually occur both over the supratemporal arcuate bundle as well as over the inferior arcuate bundles. So it's beautifully demonstrate that the damages happen in both superior side and inferior side of the retina. The left eye, as I mentioned, loss is actually not very obvious, but it's only again when we look at ROTOR we can appreciate actually a loss of the axonal fiber bundles both over the superior side and the inferior side. So you can see how we can harness the information generated from OCT to get us a better diagnostic capability. Here, the ROTOR image is generated from the Triton OCT using the same 12:9 scans. So the resolution actually is not high because the scan is fast. It takes seconds to capture the 12:9 scan, and then we can generate this ROTOR axonal fiber bundle images. Obviously, when we image these layers with a high resolution scan, we can get a much better resolution. You can see the axonal fiber bundles of the buffet, and you can see obvious loss of the axonal fiber bundles over a wide field. Again, the same supratemporal and infratemporal retinal nerve fiber defects for both the right side and the left side. So with ROTOR, here is the high resolution ROTOR, we can get more information. We can get the individual trajectories of these axonal fiber bundles. So again, this is another example demonstrate to you why wide field imaging is important, because when we look at the rim, here is another case, we don't see any abnormalities. Only when we study the retinal nerve fiber layer over the wide field, we can appreciate the damage, obviously. The reason why we don't see any abnormality in the rim is that for damage like this eye, it's a very focal loss of the axonal fiber bundles. And you can see the wedge shape of the retinal nerve fiber defects. It's only when we go beyond the optic disc region, we can appreciate much better the abnormality because of the wedge-shaped feature. We see wider loss of the RNFL when it gets closer to the macula. When you only focus on the rim, you're going to miss the abnormality because the damage here is relatively focal. So the key lesson here is you need to go beyond the rim. You need to go beyond the circle assessment of the retinal nerve fiber layer. You actually need to look at the macula so that you get a comprehensive assessment of the damage of the optic nerve. So again, why do we need wide field imaging for evaluation of glaucoma progression? We need wide field imaging for detection of glaucoma, but do we also need wide field imaging for evaluation of change in the detection of glaucoma progression? The answer is yes, because here is a study we did some years back demonstrating that sometimes we do see our NFL change first over the optic disc region before we see change over the GCIPL at the macula, but sometimes it's vice versa. Here is an example demonstrate to you. Here we see our NFL change after we see change over the macula. But on the other hand, in this example, we see change of the RNFL takes place before change at the macula. So that's why it is important for us to capture both the macula and the optic nerve head region in order to maximize the probability to detect glaucoma progression. In this study, we demonstrate both the retinal nerve fiber layer change and the GCIPL change, they are mutually predictive to each other, and they are both predictive of future loss of the visual field. This is important because we provide IOP lowering treatment because we want to reduce the risk of visual field loss. So that's why when we see the intraocular pressure is high, we provide therapy to lower the intraocular pressure. But here, when we see loss of the retinal nerve fiber layer, when we see loss of the GCIPL, we need to be careful because this also tells you that these eyes are at a high risk of development of future loss of the visual field. So how do we integrate our NFL and GCIPL analysis to detect glaucoma progression? Here we use a technique called TPA, or trend-based progression analysis. TPA performs pixel by pixel linear regression analysis between a thickness of interest and time. The upper panel here shows the progressive change of the RNFL thickness. Here, the change map here in the second row in the upper panel. The red intensity, the higher the red intensity indicates the faster the rate of change of this layer. The upper panel shows the progressive RNFL thinning. The middle panel shows you the GCIPL thinning. Here we see retinal nerve fiber layer loss before we see GCIPL loss. The question here is that when we combine the two layers together, when we combine RNFL and GCIPL together for TPA, are we able to see change earlier? The answer is yes. Here is the same example demonstrates that when we combine the two layers together for TPA, for trend-based progression analysis, we actually can detect change earlier compared with change analysis of the individual layer. This is the rate map. Again, increasing intensity of red indicates faster loss of here RNFL GCIPL layer, the combined RNFL GCIPL layer. What you see here is the inferior arcuate bundles is the region where you see the fastest loss of the RNFL GCIPL. Again, here another example, the same message. We can detect combine our NFL GCIPL thinning first before we see change of the individual layer. More importantly, what we also witness here is that change of this structure occurs before change in the visual field. This is the rate map demonstrating to you again the inferior arcuate bundle shows the very fast rates of loss compared with the other region. When we see loss of the RNFL GCIPL layer, when we see progressive change in this layer, this eyes actually carries a more than twofold increase in risk of development of possible visual field progression. Here we use the GPA, or guided progression analysis, to measure visual field progression. And here the bottom panel show when we have eyes demonstrating progressive RNFL GCIPL thinning, this eyes carries a more than fourfold increase in risk of development of likely visual field progression. Not only we see change earlier when we use the combined GCIPL RNFL layer analysis, but also we are able to detect more change. So in other words, when we go deeper, when we combine the two layers together, we can actually detect glaucoma progression that would be missed by either the progressive RNFL thinning analysis or the progressive GCIPL thinning analysis. So again, the take-home message here is that we need to go wider. We need to study not only the rim, not only the optic disc region, but we also need to study the macula. We need to integrate both regions in order to improve the performance for detection of glaucoma and its progression. And second, we need to go deeper. When we are able to combine the two layers together, when we are able to combine RNFL and GCIPL together, we are able to detect change earlier, and we're able to detect more change compared with the progression analysis of the individual layer. And then finally, I show you ROTOR is a very exciting new technique that enable us to visualize the individual axonal fiber bundles. And I look forward to share with you how we apply ROTOR for evaluation of glaucoma progression in the future. Thank you.